Good afternoon and welcome to West Berkshire Health Scrutiny Committee. I'm Councillor Claire Rolls, Chairman of the committee. I'm supported today by Councillor Alan Macro as Vice Chairman. Other members of the committee in the Council chamber this afternoon are Tony Linden and Andy Moore. Councillor Graham Bridgman is also present as Executive Portfolio Holder for Health and Wellbeing. Council officers and external partners joining us to advise and support the meeting are Hugh O'Keefe, Senior Commissioning Manager for Dental Services in the NHS, who I believe will be joining us. Andrew Sharp, Chief Officer from Health Watch Berkshire, again, who hopefully will be joining us. I see his colleague Leslie Wiseman. Welcome, Leslie, joining us from Health Watch as well. Andy Sharp, Executive Director for People at West Berkshire, and Katie Summers, who's Director of Place Partnerships at the CCG, will be joining us around 2 o'clock. Gordon Oliver is the clerk for the meeting. And the meeting is also being live streamed via YouTube, and Christine Alsassa is the Zoom host. Before we start, I'd like to explain for the benefit of members of the public who may be watching that today's meeting will be a hybrid format, both over Zoom and with members present in the council chamber. During this meeting, I would ask that anyone wishing to speak to raise their Zoom hand. All voting will be done by a show of actual hands. Does anyone have any questions before we begin the meeting? I'd also just like to add, for any members who are non-members of the committee and not members of West Berkshire Council, if they do wish to speak on any item that is not their own agenda item, that I'll have to suspend standing orders to enable to do that. So I would welcome if you could put any comments in the chat as we go along. It just might keep the meeting moving in terms of bulking those together in suspending standing orders at the appropriate times. Okay, so we'll start by apologies. Gordon, do we have any apologies for absence?
Yes, Chairman, we have apologies from Councillor Jeff Beck, and Katie Summers has said that she will be joining us later in the meeting.
Thank you. Moving on to minutes. Are there any comments or amendments to the minutes of the last meeting held on the 11th of August? I don't see any hands going up. Can I have, therefore, a proposer to approve the minutes? Thank you, that's Councillor Linden, and a seconder. Thank you, that's Councillor Moore. And can we have a vote on that? Thank you very much. I'm just going to sign those as a true and accurate record. Thank you. And moving on to declarations of interest. Do we have any declarations of interest?
I haven't received any before the meeting, Chairman.
Sorry, I didn't hear that. Thank you very much. None received. Moving on to item number 4, petitions. Do we have any petitions?
We haven't received any petitions.
Thank you very much. Okay, so moving on to agenda item number 5, Health Scrutiny Committee Prioritisation Methodology. I'd like to invite Gordon Oliver to present the report.
Thank you, Chairman. So members, this report presents a proposed methodology that has been designed to try and help the committee in prioritising health topics to consider for future scrutiny. Prioritisation is something that is encouraged within the government's statutory guidance on overview and scrutiny in order to ensure that we focus our activities that deliver the greatest value and impact. In putting together our prioritisation tool, we have drawn on advice from the Local Government Association and the Centre for Governance and Scrutiny. We've also looked at what other local authorities are doing elsewhere. So the proposed methodology focuses on 5 criteria under the PAPER acronym, and these are 1, public interest, 2, area affected, 3, performance and priority, 4, effectiveness, and 5, resources. So a rudimentary scoring system has also been proposed, giving each proposed topic a rating of between 1 and 3 for each of the criteria. So inevitably, there will be an element of subjectivity in making assessments and allocating scores, but the tool really is only intended to act as a sort of guide to aid decision-making, and members may wish to use it with or without the scoring system, depending on the number of competing topics being considered.
Thank you. Do we have any questions? Any comments?
I mean, I guess my only question really would be, so each time we get a topic, somebody, Gordon, presumably, will have done an assessment, and so we get an idea as to what the priority assessment says is. Thank you. Okay, that's useful.
Yeah.
It seems to have picked up all the right sort of guidance and be a very good starting point.
Yeah, Councillor Linden.
Thanks, Chairman. I would like to propose officer's recommendation.
Do I have a seconder? Thank you, Councillor Macro. And can we vote on that? Thank you very much. I'd just like to add, I'd like to thank Gordon for his work on this, particularly seeking to look at what other authorities have done in terms of best practice. And I think it sets a good model in terms of potentially doing this in other areas of the council. So I was very pleased with that, and thank you very much. Like that noted. Okay, just so moving on to protocol between West Berkshire Health Scrutiny Committee and local health bodies. Again, I'd like to invite Gordon to present the report.
Thank you, Chairman. So this report outlines a draft protocol that sets out how the Health Scrutiny Committee will work with local bodies that commission or provide health services for local residents. So the requirement for a protocol was incorporated into the terms of reference for the committee when it was set up originally, and it's intended to set out how we will engage with local health partners. So the aim of the protocol is to provide improved engagement and communication between the various parties, clear standards about how the parties will work together, confidence in planning for service change. And the protocol includes a number of working principles as follows. So the first one is a no surprises approach on both sides. Number two, there'll be a climate of mutual respect and courtesy between all parties. And number three, we will use an evidence-based approach as far as possible. Fourthly, proposals will be informed by the views of local residents and service users. Fifth, our approach will be transparent, collaborative, constructive, and non-confrontational. And then finally, there'll be an acknowledgement that there may be disagreement about what constitutes best outcomes for local residents. So the protocol also sets out the factors that will be considered when determining whether a proposed change in health service is substantial, thus triggering a formal consultation with the Health Scrutiny Committee. So factors that will be considered include changes in the accessibility of services, changes to the methods of service delivery, impacts on service users and their families or carers, impacts on health and social inequalities, implications for service quality, deliverability and risk, and finally the effects on other health services and the wider community. So initial consultation on the proposals would take place with, has taken place with the chairman, initial consultation on any proposals will take place with the chairman and vice chairman of the committee, who would then make a recommendation to the rest of the committee as to whether they consider the proposed change to be substantial. So the protocol is closely based on that already used by Oxfordshire Joint Health Overview and Scrutiny Committee, and I would like to thank them for very generously sharing their protocol, which they have been using for some time and which they consider to be effective. And it is already sort of understood and widely used by their health partners.
Thank you very much. Are there any questions, members? Councillor Bridgman.
Chairman, can I perhaps defer to the committee first and come in after, because obviously the committee may want to make points I might want to make, but you know, speaking as it were from the floor, perhaps the committee gets its chance first. I'll come in when you've all had your chance to question Gordon on it.
Thanks, Councillor Bridgman. Councillor Moore.
Thank you, Chairman. I mean, this all seems, you know, very sensible and appropriate. My major question really with it is, if you look at the protocol document itself, and it goes to go to paragraph 5.1, the application of the protocol. It says the protocol is an agreement between ourselves and those bodies who commission and provide health. And my experience of protocols tends to think, well, this is something where there's a signature, and you've agreed something by jointly signing a document, which kind of goes back to my point in my question last time out, which was how many protocols, because there are a lot of potential bodies that we will be dealing with, and I'm not quite sure how I see the agreement is being made, other than in effect we're publishing the protocol and just expecting them to just fall into line.
Yeah, can I just come in on that? So the recommendation is, a part of the recommendation is that we authorise consultation with local health partners on the protocol, with a view to bringing a final version back to health scrutiny for approval. So that will enable our partners to have a say on the proposed protocol. That's my understanding. Councillor Linden.
Yes, Chairman. Obviously, we're really on the start of the formal consultation proposal. We've obviously got our agreement with our two other unitaries, Reading and Woking. And of course, we've got Oxfordshire and Buckinghamshire that we'll be meeting on a regular basis, both yourself and myself. I just wondered if, Gordon, if you've got updates when we're likely to have meetings of what's called the Bob, and if you want to go any further with that in terms of more formal consultation, in terms of meetings that we'll be required to have. Thank you, Chairman.
Yeah,
Through you, Chair. I'm not aware that any meetings of the Joint Health Scrutiny Committee are actually proposed at this stage. The last I heard, Oxfordshire were leading on drafting a protocol that would be used by the new committee, and were liaising on the need for future meetings. So they seem to be taking the lead at this stage, but I haven't been advised as to any sort of clear meeting dates yet.
thank you. Councillor Macro.
Thank you. Am I right in thinking that because we've based our protocol, or draft protocol, perhaps I should say, on that used by Oxfordshire, then we should have a following wind when it comes to getting agreement with the other bodies?
Gordon, did you want to comment on that?
Yes, it's a good question. I would have expected that, because a lot of the health partners are the same, then especially with a move towards the Buckinghamshire, Oxfordshire and Berkshire West ICS, then hopefully people should be familiar with it and accepting of it. And that was one of the primary reasons for trying to model it closely on the Oxfordshire model.
Thank you.
Councillor Bridgman.
Thank you, Chairman. And Councillor Moore really asked the question I was going to ask, which was about, sort of where to from here, looking at the report and the fact that it's referred to in your terms of reference as a joint protocol. This is the age-old question: what happens if one of the bodies doesn't like a particular line or something? How do you square that circle? But so as I say, Councillor Moore really asked that question, and it's been answered. I guess following that up, though. Certainly, so far as a JHOSC protocol is concerned at Bob level, I guess that the extent to which you can align this draft with their draft, as Councillor Macro intimates, you won't get as much pushback from anybody because they'll have all agreed it sort of already. But more to the point, everyone will be singing from a similar hymn sheet all the time, rather than having to worry about what this protocol says or that protocol says. So the extent to which you can get them all lined up, I would have thought was a very good idea.
Thank you, Councillor Bridgman. I think that's right. I think it's probably going to be a timing piece around the whole consultation. So I think if we can get that right, it should all dovetail quite nicely in together, because at the end of the day, protocols are only as good as the engagement that you have from all parties. So I think that's a point well raised. Councillor Moore.
Thanks, and sorry to just return to that question I had again. I mean, perhaps given that what you've said, there's a consultation. Well, obviously, and rightly. Could we have something in the protocol itself which says that consultation is concluded successfully? Maybe list the bodies that we've consulted, and and even possibly some sort of reference of their agreement, reference to their agreement, notes of a meeting or their response to the consultation. I just, it just in going forward, what we don't want is anybody coming back to us and saying, oh, well, no, sorry, we never saw this in the first place, or we never agreed to it, or, so it just needs to tidy that up, I think.
Yeah, if members are in agreement with that, I think that's a very sensible suggestion. And I think also to at least give everybody the opportunity to comment, even if we don't receive those comments, that we've actually documented that we have reached out to those parties, I think would be a sensible suggestion. To Gordon, perhaps we can note that into the protocol. Are there any other questions or comments from members of the committee or anyone else? No. Okay, I'm just going to read out the recommendations so we're actually absolutely clear on what we're voting on. So the recommendations are that we endorse the draft protocol and process for dealing with proposed substantial developments of variations to health services. And number 2, we authorise consultation with local health partners on the above, with the comments noted from the committee, with a view to bringing a final version back to health scrutiny for final approval. Do I have a proposer for that? Thank you, Councillor Linden. Do I have a seconder? Thank you, Councillor Macro. If we can all vote. Thank you very much. I think that's unanimous. Thank you, members. And once again, can I just thank Gordon for all his work on the protocol. These things take a lot of time, particularly when you're liaising with other authorities. And I think he's done a very good job bringing that to the committee. So thank you once again. So moving on to NHS dentistry, do we have Hugh? Is that Hugh O'Keefe on the line?
Hello, yes, I'm on the phone. Can you hear me?
Yes. And thank you very much for dialing in. Welcome to the committee. Can you hear us? Can you hear me?
Yes, I can, thanks, yeah.
Okay. Well, I'm inviting you to present your report.
Thank you. Yes, sorry, I've tried to come in on the Zoom, but that's proved unsuccessful. So, yes, you've had a paper about dental services describing the current situation both nationally and locally. I think
sorry,
some of the key
can you speak up a little bit if you don't mind?
Yes.
It might be me being a little bit hard of hearing.
I'll go nearer to the phone just to make sure you can hear okay. So currently dental services are running at 65% of full capacity. And this is really due to the safety requirements involved in treating patients in the dental surgery. What this means is that dental practices are having to prioritise the patients they see, and that tends to mean that patients seeking routine checkups tend to come to the bottom of that list. The prioritisation criteria that are being used by the dentists are set nationally, so there's clear guidance in terms of who should be at the top of that list. But the capacity to deliver services within that prioritisation criteria is defined locally by the practices. So this is why you may be seeing some local variation in terms of people being able to get in to see the dentist. And it's worth saying that NHS practices have quite variable levels of commitment in terms of the amount of NHS service they deliver. So in the light of this situation, we are taking some local actions to try and support access. So additional access sessions have been offered to the practices for patients who don't attend the dentist on a regular basis. So just to confirm, no one's registered with the dentist. And it tends to be about 50% of the population will attend the dentist on a regular basis, and then others will either go privately or just attend when they have a problem. So the additional access sessions is trying to open up the system for those who don't go regularly. And then we're also running looked after children pilots, because this has become an issue with children potentially moving around and trying to get into the system. We're also investing significantly into community-based referral services, which is community dental services, and Tier 2, which is out-of-hospital specialist oral surgery services. And that's in the period up to the 31st of March 2023. And really what we're trying to do with these sort of arrangements is either keep the system as open as we can, and we are looking at other possibilities in terms of how we might do that, or try and stabilise the situation in terms of long waits for treatment. But we recognise that whilst we're operating at below full capacity, this backlog issue and access issues is going to continue. One thing that we would like to request of patients is if they are offered appointments, can they please make sure they attend? We are getting some feedback about failed to attend being a bit of a problem for practices. They're setting aside the capacity to see the patients. Often, if the patient has not previously attended, they will be setting aside quite long slots to see those patients. So it's really important that the patients do attend those sessions. I think the other thing to flag for the committee, just to for awareness, is that I think in line with many other services, we are seeing emerging challenges around the workforce. So recruitment and retention linked in some respects to the pandemic. It's been tough working conditions in dental practices now for a good 18 months, and that is having an impact on that. And also we're seeing more dentists now wanting to work part-time on the NHS. So it's going a little bit the way of the doctors in terms of doing shorter amounts of NHS commitment. So we're needing more dentists to keep up with the demand for services. So in terms of where we are with the capacity, and the figure I quoted at the start of 65% is nationally defined. That is subject to review from the 1st of January 2022. And then there's a national review happening about contracting arrangements, possibly then from April, to see if we should be looking to, really as a result of this pandemic, be putting in new types of sort of incentives and systems into the contracts. I think we should note that whatever happens in the next 6 months, this issue is going to be with us for some time to come. Thank you.
Thank you. Members, do you have any questions? Councillor Linden.
Yes, I'd like to ask you, Mr. O'Keefe, is about ages of dentists and also orthodontists and hygienists as well, because in particular in the GP area, we have a problem of a lot of doctors who are going to be retiring or are post 65 to 68 age ranges, as well as people leaving to do other things because of pressure on the NHS. Could you just elucidate how this affects NHS dentistry as such, please?
I think it's less of a problem for the dentists. The sort of arrangements that we've got at the moment for dental services came into effect in 2006 with a new contract at that point. And that was accompanied nationally by significant investment into NHS dentistry. So in this area, we've seen, and by which I mean the sort of Thames Valley, Berkshire, Buckinghamshire, Oxfordshire area, we've seen a sort of 30% growth in the number of patients attending the dentist over the last 10 years. And that's been through, a lot of that has been through increased capacity. And it's actually a relatively young workforce that's come through to take on that additional capacity. I think more of the challenge in dentistry is there is a sort of more of a mixed economy in terms of how it works. And so it's whether people, with the stresses on the system at the moment, and that there is a sense with the dentist that although they're working at a sort of lower target for their contracts. The level of the nature of treatment required is a sort of heavier case mix than before, making it a much tougher working environment. And I think that's becoming increasingly a factor in terms of whether people look to either stay in their profession or look to move across to the private sector. And we're aware we've been okay really in this area, but we are aware. Places like Sussex and Hampshire, they have been losing dental practices.
Thank you, Jim.
Councillor Macro.
Thank you, Chair. I remember reading a few weeks ago that a very high proportion of children being treated in hospital, and I think it was over 50% by memory, were there to treat dental problems. And it struck me that this is apart from the pain and everything involved to the child, seems to be an incredible waste of resources, because most of those problems, I'm sure, could have been caught by a dentist at an earlier stage. And I was wondering if there's anything that you're planning to try to address that.
So, there's a very strong link between socioeconomic factors and dental extractions in hospitals for children. I think I saw a statistic 2 or 3 years ago that about 40% of the Berkshire Community Dental Services work in terms of extraction came from 4 postcodes. So it is a sort of, and nationally that's kind of reflected. And in our patch, Slough, I think, has been identified as one of the areas in the bottom 13 nationally in terms of oral health. We've sort of been involved locally in a thing called Starting Well, which has been trying to work with dental practices to more proactively promote oral health in their local communities. Particularly, we've been running a project in Slough. I have to say it's all now been on the back burner now because of the COVID impact. So there is a sort of national push to try to do this, and this is potentially what people are going to try to look at in terms of contract redesign. There's been a program that's been running for about a decade now in terms of prototype contracts, which are with a much bigger focus on prevention of oral disease. Now that's going to be wound up from March 22. And I think one of the challenges that program has faced is balancing access versus more intense sort of work with patients in terms of prevention. But we think there's a sort of balance we need to strike in terms of making sure that dental services are absolutely getting at the people in the greatest need. So it does remain a sort of ongoing debate, and I think some of these Starting Well type projects we're going to look to reactivate once we can get over the sort of peak of this pandemic.
Thank you.
Just following on from that, Mr. Oakey, can I ask just the point around sort of the preventative piece, and hygienists have been mentioned. Is there any sort of particular initiative or anything? You mentioned hygienists briefly, but is there anything around that we're doing to try and improve that in the light of that? I think that this may, sort of come back to haunt us slightly, where we're not addressing the sort of root causes, and that's not a pun.
It is part of this, the sort of pilot prototype projects that have been run is trying to look at skill mix, and that's part of the consideration of the resource, so that there's maybe the people who are involved in the more preventative work don't necessarily have to have the same level of dental qualification as the dentist, so that those resources are targeted appropriately. And so that is being looked at. That there are things being done through Health Education England about training pathways now, which would allow people to sort of move through dental nurse up to hygienist up to dentist if necessary over the period of a career, rather than maybe just coming out in very segregated ways of working. And they're also running some pilot work in a new course that's being run by Health Education England, which is then about training people in terms of doing more work on their oral health promotion, because a lot of that can be done with groups of patients, doesn't have to be individuals, doesn't have to be done in the dental surgery. Historically, the community dental services have done a fair bit of this work, but really for it to take effect in a population, we've got to get it done at a sort of critical mass level through the high street dentist. So yes, it's definitely been looked at and worked on, and then it's been considered about how we take the contract forward in the future, but also having an eye on the fact that in doing this, we're going to have to try to maintain access for the population as well.
Thank you. I have a question from Andrew Sharp at Healthwatch. So can I suspend standing orders? Can I have a proposal for that? Councillor Macro, seconder. Councillor Moore, just a vote on that. Thank you. Andrew, the floor is yours.
Thank you, Chair. Thank you, Hugh, firstly, for finding the time to come, and thank you to the committee for putting dental so early in their schedule. It's without doubt the current thing that we receive the most information about from the public of West Berkshire. This is actually reflected across the whole Healthwatch network. I mean, it's almost difficult to find a question, because I think, am I right in thinking, Hugh, that while we continue operating at 65%, the waiting lists month by month increase rather than decrease, because obviously we're not operating at capacity? And I do absolutely accept the challenges you've got with that. So yeah, it's really interesting that when you look at physical health, with the acutes who are operating at 110% capacity on certain specialities to try and hit their waiting lists, it really feels like NHS dentistry is just not being given the help to actually be able to recover. So you're almost saying to a question would be, well, when do you expect normal access to return? I've had an email filling up this morning from someone saying they've just managed to book an appointment, and the first date they can get is March 2022. And it may not be an emergency, but I was looking through the list going, in terms of even emergency treatment for NHS patients, how much resource have we got in West Berkshire? And I wasn't even sure I could find a dental practice in West Berkshire on the list. I apologies if I've got that wrong. So yeah, so I'm sort of hopeful that I think dental needs so much attention, both locally, across Bob, nationally. And do you feel that the ICS getting involved from April will have a positive effect on this? Thank you.
I think it will. I think they will find, a bit like yourself, Andrew, that quite quickly it's going to be a fairly high profile issue in terms of the feedback they're getting about the services. We are starting to sort of meet with them, and they're involved in our sort of dental commissioning group, looking at the way forward for services. I mean, what we are looking to invest where we can to try to address some of these issues, and I think we've had pretty good success in terms of the things like the community dental services and the referral services, where there's clear sort of waiting lists, and there's good take-up from the providers about trying to address those, and that's all sort of kicking off this month, really, in terms of happening. With the dentist, I think it's one of the things we are doing, and again, this is a national sort of process, is this sort of income guarantee they've got, which essentially means that if they now hit this lower threshold of 65%, which is allowing them more time to treat those patients who don't normally attend and have urgent need, then they retain all the funding that they get paid. There's a sort of contractual arrangement. If they sort of drop below 96% normally, we then recover that money. So that is sort of in effect leaving that money in the system. So in effect, that is a kind of extra investment into the system compared to what we would normally spend. We think that is been helpful in that respect. In terms of the other schemes we're offering to them, because they're independent contractors, they don't have to take them up, and so they have to take a view. As a business, is this sort of thing for them, and that's why we're having to continue to look at what are things we might be able to do that could work and also fit within the rules. So that's an ongoing process really, and certainly we'll be working with the ICSs on that.
Thank you. Sorry, I think we need to reinstate standing orders unless there's any other questions from Andrew. No, okay, I think we reinstate standing orders. Proposer, Councillor Linden, seconder, Councillor Moore. Vote gone through. Councillor Moore, did you have a question?
Yes, I did. Thank you. And thank you, Mr. O'Keefe. I just wanted to try and get my understanding about the private versus NHS situation here locally. I mean, would it be true to say that almost all practices that are offering NHS services are also private dentists?
Yes. So yes, I think that's right. So you have some practices that are fully private. Don't see anyone on the NHS. Children, adults are all treated privately. Then you have some that just see children and charge exempt patients on the NHS, and they really have quite small contracts with the NHS, and essentially private concerns. But even those that have got substantial NHS contracts, they may have a contract that's somewhere towards £1 million a year with the NHS, will also have a private part that goes with that. So it is very much a mixed economy in terms of how it works.
And so if capacity is a problem, NHS capacity as it were, what is the incentive or what's the disincentive that an NHS practice or a practice that's offering NHS services, what disincentive is there to try to sort of, as it were, encourage the patient to take the private service? I can put that very clearly, but I hope you get the gist of that.
Yeah, I do. The point here is that the patient should always be making an informed decision about what they're going to do. So what the practice should be doing is clearly explaining what the options are for the patient in a way that allows them to make an informed decision. And any sort of should we call promotion of private work when it's clear that the person would prefer to receive NHS treatment is something that we would review, and that can involve the follow-up in terms of the performer, in terms of the professional practice, if they seem to be sort of pushing private versus the NHS. I think it is difficult at the moment in this current situation where practices are identifying a certain level of capacity they set aside for NHS work, and sometimes this will be actually in terms of physical surgery space. So there'll be 3 chairs for NHS and 2 are for private in the building or something like that. And they sort of set aside a certain amount of surgical time each day for the NHS work, and they are booking patients in on the NHS side of their work. And if that system is then full, they could then say to the patient, there is the option for you to be seen privately if you want to be, but it really needs to be a situation where the patient feels they are making an informed choice about what they're doing. And, if there's any patients ever have concerns about that, we will follow up and see what the practice has told the patients in that respect.
Okay, that's very helpful. Thank you.
Thank you. Are there any other questions? Yeah, I'd just like to add, I'd just like to thank Hugh, Mr. O'Keefe, I'd like to thank you for coming along. I think we appreciate the pressures that everybody's been under, and so very much have welcomed your input to today's committee. So thank you, and you're welcome to join us, or if you want to drop off the line, that's fine too. Members, there is no recommendation associated with this report, so we are simply asked to note it. Okay. Thank you. So moving on to agenda item 8, access to GP surgeries. I'm not sure if we've got Katie Summers with us. Gordon, have we heard anything or any Zoom?
I haven't heard anything from Katie Summers. It may be worth just taking another agenda item and just moving around. Yeah.
I suggest, members, we therefore move to agenda item 10, as Katie was going to provide the CC update for agenda item 9 as well. So can we move to agenda item 10, which is the Health Watch report? And I'd like to invite Andrew Sharp and Leslie Wiseman to present the report. Thank you.
Thank you, Chair. Leslie, are you there?
Yeah.
Excellent. Hopefully, we can put the report up, but actually it's sort of been noted for information. So if I can hand over to Leslie, who was involved very much in the writing of the report, then I think she'll be able to answer most of the questions, and I'll pitch in if needed. Thanks.
Good afternoon, everybody. So my name is Leslie Wyman, and I am on the board of Health Watch West Berkshire. I'm retired, and I was a public health consultant at West Berkshire up until 2016. So I think I even recognise a couple of faces, which is nice. So this survey was one that we undertook in February 2021. It was an online survey specific to West Berkshire residents, and asking parents and guardians of children and young people who were either using the local CAMS services, which is Child and Adolescent Mental Health Services, or who had used CAMS previously. We were pleased to get 128 responses, which is quite a good number, and I was able to undertake the data analysis and looked at it both from a quantitative standpoint and also qualitative, because there were an awful lot of comments that we had. You'll see in the report, in the executive summary, that I referenced the technical report by the Children's Commissioner on the state of children's mental health services in 2021. This is important because it gives us some insight into these services, both in Berkshire West, CCG, but also nationally. The report looked at numbers of children's referred and accessing children and young people's mental health services, numbers that are not accepted into treatment, average waiting times, and spending as a proportion of the whole CCG budget. Generally speaking, the report showed a big increase in referrals nationally, and it goes from 2017-18 up to 19-20. So Berkshire West was no different here, also seeing a considerable increase in children being referred to the services. But unfortunately, the rises in those accessing treatment increased at a slower rate than referrals. So there were sort of problems here. The report also talked about the effect of the pandemic, which in our report we do mention as well. We do talk about this because it certainly in some way accounted for the increase in referrals and in children and young people suffering mental health problems. But they do point out that this risk, there is a risk, sorry, that the increased need is likely to continue. It's not going to stop because we have because the pandemic has started to drop off. In terms of the CCG itself, one of the reasons that we did reference the report was that unfortunately Berkshire West CCG was listed in the 10 CCGs who had the largest increase in waiting times from 1718 to 1920. So it was in that bottom 10 CCGs. This average went from 38 up to 60, although there was a decrease between 1819 and 1920 from 65 to 60. So it kind of peaked in 1819 and started to come down in 1920, which was a bit of good news. There was also something I just wanted to mention briefly. Another good point in favour of Berkshire West is that the report looked at the proportion of children and young peoples whose referral to CAMHS was closed, and they are trying to, obviously for this to decrease this number. They don't want significant problems to be ignored and not to be referred at all. And Berkshire West and actually Berkshire East had the biggest decrease in that number of children and young people whose referrals were closed. So they're obviously turning things around quite well in terms of actually keeping them on their list for referrals. There wasn't a lot to say about spend, mainly because they in the report only looked at the top 10 and the bottom 10, and the Berkshire West CCG is somewhere in the middle. So I can't give you that actual figure. So going back to our report, you will see in the executive summary that the main issue that came out of the survey was waiting times, very long waiting times. Around half of the people, 50% who responded, reported 1 to 3 years wait to be given a diagnosis or to access CAMHS for any reason. Now, 93% of those respondents were school age. So, they were not very young children and they were not over 18. They were mostly, as I say, 93% were school age. I pulled out some of the responses for what this meant for families. And they said things like that it affected the children and young people's education. So it also, it adversely affected other family members. And also, as you can imagine, they felt that the condition of their child or young person with mental health problems worsened because they were not seen by anybody. 3/4 of the respondents reported that an earlier access would have made a difference to their child. There was also some considerable dissatisfaction with the service itself. 6 out of 10 said the service did not make a real difference to their child. 7 out of 10 were not happy with the information they got on discharge, and 8 out of 10 wanted more information about where to get help. There were many comments asking for the waiting times to be decreased, for there to be better communication in general with the family and with the children and young people using the service throughout the whole CAMHS journey, from referral through to discharge. So, in terms of my recommendations, I knew if I wrote these down that I would definitely get them mixed up. And I have, of course. So the recommendations just are very simple and straightforward, and they basically fall out of those comments and that data. It's just about trying to increase, trying to decrease the amount of weight that there is, trying to improve the communication throughout the journey, and a bit like actually going back to our previous speaker, Hugh O'Keefe, looking at trying to improve prevention and early intervention, which will decrease their need for referral into CAMHS in the first place. So that was really important. But I would like to say, just in conclusion, that on the CCG website, there is now the refreshed version of the Berkshire West Local Transformation Plan on children and young people's mental health and emotional well-being. I quoted and linked our recommendations in with the plan that was actually refreshed in 2019, and this plan has been written in September 2021. So I've been through it actually, and it goes through the priorities that we outlined in our report, and also what progress has been made, and also the Children and Young People's Mental Health and Emotional Wellbeing Service Review is fully outlined as well in that plan, which actually gives a lot more information and a lot more explanation and understanding of the whole CAMHS service. There is also now, of course, refreshed priorities and how these will be met, and those are all set out as well, what will be done and what will success look like. So although our report does highlight that there are still many waiting for far too long to be seen, and those that are seen are not always satisfied with their treatment, it is a small survey. And reading through the LTP refreshed plan, I think does give me a lot of reassurance actually that the commissioners are continuing to focus on and improve children and young people's mental health locally. And it's up to us as Healthwatch really to support that in any way we can. If there are any questions that I can answer.
Thank you, Leslie, for that very comprehensive summary and overview. Sorry, just before we go to questions, I'd like to welcome Katie Summers to the meeting. Katie, just to let you know, we're on agenda item 10, so we'll come back to your agenda items after this point, but we can take questions. So Councillor Linden.
Yes, hi Leslie again, long time no see. Yeah, I was quite struck by about half the people or more were dissatisfied with what was happening with their children in terms of response. Also, the ages were quite interesting as well, waiting to access CAMHS. I know this is a small number of responses, and it is a bit difficult to crystal ball gaze. And I know you said you're confident, but it is, these sort of figures are not fantastic, really, are they? But do you think it's the people who responded were the people who had concerns rather than those who are more satisfied? Because obviously there must have been a much larger, significantly larger number of those people accessing the system.
Yeah, well, it's hard to say. Obviously, there were some respondents who were satisfied. The number was relatively small in comparison to those that were not overall satisfied. But I have to say that in these kinds of surveys, it's not surprising that the people who are unhappy and have a high degree of anxiety that things are not going right for their child, their family, that it could be that we got more responses from those people that were dissatisfied. but it's difficult to say really. Andrew, did you want to come in on that at all?
Yeah, I think we were told, just to give you a sort of outline, that the CCG said approximately they get something like 1,500 referrals a year across Berkshire West. So even if you do a sort of very basic split between the three, that we're guesstimating what Berkshire West Berkshire should probably be between, I don't know, 400 and 700 a year. So although 128 doesn't sound a lot, remember it's just West Berkshire. So I think it is significant, and I think we've got to get away from for every person that fills in the survey or every person that complains, there's 100 who don't, based on Healthwatch England's research. So yes, it's not thousands, but I think the thing that kind of troubles me is the general tone, and it is brilliant that it is being addressed. But I think what is worrying as well is it the weight that people feel is determining that the service isn't as effective as it could be? Because I think there's a few quotes around that sort of lane that it took so long. So although the service gets a little bit of criticism, you almost do sort of wonder whether is it the fact that people have waited so long and had to deal with the situation for so long that either the situation with their child has got much, much worse, or there was a propensity to be disappointed. Or from the focus groups and people I've spoken to, I think there's this sort of feeling that nothing much happens until diagnosis. And then I think because it's all so traumatic for the family up to that point, I think there's this sort of inner hope that something magic will happen once you get actually into the treatment, which is probably an over expectation anyway. But of course, these are people who are living this every day. So I just think it's, with all the things we're trying to do with the new joint health and wellbeing strategy, I think this is just a reflection. The pandemic's probably made it worse, and I think we've got to maintain focus. I think that's what I'd like to say, really. But a huge thank you to Leslie as well for all the hard work on this.
Thank you. Councillor Macro.
Thank you. Yes, I was going to ask something similar to Councillor Linden, but reading this, I was absolutely horrified, to be honest. People waiting, in some cases up to 5 years, but typically up to 3 years for on the waiting list. And then when they do get treated, they say, well, it didn't make any difference. And of course, all that time, not only is the young person involved suffering, but the family are suffering and suffering from stress as well. And I wonder how many of these kind of incidents probably lead to kind of family breakdown. But the question I was going to ask really is, how confident can we be that this kind of transformation plan is really going to help? Okay.
Leslie, quickly comment now.
Probably not an answer for me, maybe more for Katie.
Yeah, that's true. Yeah.
to answer, I guess.
Katie, do you want to come in?
Sorry, I was just a bit distracted. You just repeat the question. I'm so sorry.
It was how confident can we be that the transformation plan are going to help with these problems along waiting lists and families feeling that the treatment hasn't helped?
So speaking with Nikki Cartwright, who is the responsible officer here for CAM services, I do feel that actually the transformation plan has been updated. They've been looking at the pressures that the children and young people have been put under regarding the waiting lists as part of COVID. They are working incredibly hard to support that. Equally, the NHS has given additional funding through to integrated care systems quite recently. So I think it's fair to say that there is quite a lot of confidence that there is going to be tackling of the problem. However, I'm saying that in one breath, and in another breath I'm saying, I think what has happened is the demand for CAM services has probably substantially gone up as a result of lockdown. So there is still this overarching issue in the fact that actually we've got to be responding in a reactive way. However, what is the role in order to support much more greater preventative services to support early incidences, so before they actually go up through to a level 3 CAM services. So I think this is the balance that's actually required as such going forward. But I do know that a plan's coming back to the Health and Wellbeing Board in it's either December or January. Gordon will be able to tell us as such. And I think that's where we could probably look at what's going to be the response in order to balance out that increase in demand going forward. So unfortunately, I can't give you a solid answer at the moment, but I think it's got to be balanced out the fact that we've had extra money, which will deal with the pressure that was here previously. We need reassurance on, is that going to meet the new demand that's put to us? And the third thing is about how can we support the very low level issues that are present in the family life as well as also the school environment to prevent people from escalating even further.
Thank you.
Any further questions, Councillor Macro? No. Councillor Moore.
Thank you. Councillor Macro asked one part of the question I think I wanted to put. The other bit really was your report, the Health Watch report, portrays some issues when people have actually got through the waiting list and are in touch. There seemed to be quite a lot around communication and that sort of thing. And I wondered what confidence there was that was being addressed in addition to the obvious one about resources.
Can I quickly comment, Leslie? Absolutely. What I think, because the report was being written and during the sort of end of lockdown, we were very much taking a photographic snap view while all the transformation work was going on. So as Leslie highlighted, the plan that's now been referred to, has changed substantially. And I think the other thing, the CCG have to be commended. We've brought the report to the Mental Health Board. They've had a look through that. We've given them the chance to respond. It's very much a sort of, there is so much work in progress that there are numerous schemes going on to try and improve matters. And I think again, I said this earlier in a meeting, that we have to not just leave this to health. This has to be a full system, all the relevant parties involved helping out, because Katie's about to do bits about GP pressure. Well, GPs are getting some specialist mental health professionals in over the next couple of years. That's going to have a positive effect. But I think really we need to try and give health as much help as we can. And also I think the communications one's important, because I think it's about managing this expectation. Because as I said, the golden thread I kept hearing was people feeling that the diagnosis is the silver bullet. And I think there's some work got to be done in terms of expectation management. And I think clearly, obviously, once people have been through the service, we've got to ensure that they do feel they're leaving the service with as much help and support and information as they can need, and perhaps lower level support from social prescribers and things like that. We've really got to get parity of esteem as a meaningful thing. And I think that the NHS is trying as fast as it can. We've also got major workforce issues. As Hugh mentioned in dental, we've got exactly the same, probably worse, Katie knows better than me, in terms of mental health professionals. So it's really got to be a sort of whole system effort to try and look at all the causes and all the potential mitigations.
Thank you. I noticed, Andy Sharp, you had your hand up earlier. Did you have any comment, or has it been addressed? I just wanted to check that.
No, thank you. It was addressed by Katie's response, so thank you.
Thank you. Members, are there any other questions? I'd just like to make one comment, and that's to sincerely thank Leslie and Andrew for bringing this to our attention and to the agenda today. I think this is an enormously important topic. As has been already mentioned before, this is ongoing. My only question would be, do you feel that it would be appropriate for us as a critical friend to put this onto our work programme at a later date to potentially sense check where we are and how things are going? And I open that up to the committee as well in terms of comments. Perhaps we'll come to that when we talk about our work programme. Okay, great. Well, thank you. Oh, sorry, Councillor Bridgman.
I was simply going to ask whether it met your paper criteria, since you've just had a discussion about how to prioritise.
Councillor Bridgman, thank you very much. Very good point. We would, of course, put that into the system, but I would like to think that it would make it at least onto the list for the protocol. Councillor Moore.
Yes, a very good point, but it has all the feeling that it should do, I have to say, and I'm sort of encouraged by the brave statements made, but and by obviously what Health Watch feel, but this feels like it's a pretty long haul before we get out. So yeah, I would absolutely support it being on the list for our continuing work.
Subject to the protocol. Councillor Linden.
Thank you, Chairman. Yes, how long is a piece of string? I would like some idea in terms of advice, in terms of the sort of time period we should roughly be looking at in terms of looking at it again, so we don't rush it or we take it too long. Do you have any ideas about that briefly?
I think what's also quite key to this that the board might like to consider is this almost certainly fits in with certainly priority, I think it's number 2 of the new joint health and wellbeing strategy, which is a 10-year strategy, I have to say. So I'm not suggesting we take over 10 years, but I wonder whether perhaps Andy or Katie might have an idea of what they might see, but if we come back in a period of time, we'll be able to witness or measure or show some change, that they may be better placed to offer that. Not too long, not too short, so this piece of string a little.
Andy Sharp. Yeah, Andy, do you have some comments?
Yeah, thank you. So one of the things that is happening across the ICP for Berkshire West is that we're looking at mental health support, including CAMHS, as a joint project within one of the ICP boards. So the underpinning work for that is due to be completed by March of the new year, rather, the end of this financial year. And then there's a plan to have that delivered over the course of the next few months after that. So I guess if you were to give it 2 or 3 months, we could probably give you a pretty decent update about where things are at from an ICP perspective. And that covers things quite broadly in terms of the support services, which includes CAMHS. Katie might have a view as to when you might want to have a look at something specific to CAMHS and the numbers around CAMHS based on the investment that's gone in over the past few months.
Yeah, just building what Andy was saying there, as he said, we've got this ICP board that's looking at this. The investment has come into place literally about 3 months ago. So I would actually say it's probably worth doing some work of this probably in March. By that point, you'd like to think that actually you would have got some initial improvements on that waiting list time. But I think building what Andy was saying, it's actually worth us probably doing that in March as an interim and then coming back again. Andy, I don't know that you read this for 6 months later to see what that progress is going forward. The other thing I'd want to build on this is you've got the health and wellbeing strategy as well. And one of those specific priorities, priority 4, is about improving the health and wellbeing of children and young people. So I think it's got to be done in tandem. You've got to understand that actually you've got this upstream work that's going on for CAMHS, but then equally you need to understand what is the actions that actually as Berkshire West that we are collectively doing through partnerships between all of the organisations, including local authority, in order to support that health and well-being priority. So I think it's got to work in tandem. I don't know, Andy, do you agree with that?
Yeah, that sounds like a very fair analysis, Katie.
Thank you. That's very helpful, and I think it's helpful that Councillor Bridgman's joined us today as well to be part of that, to hear that. Thank you. Are there any other questions? No. Okay. Can we move on to the second, the Health Watch second report, the COVID-19 Patients Experience Report? Andrew and Leslie, did you want to present that? I'm not sure which one of you wants to do that.
I just want to keep this fairly short because this was presented to the sort of Health and Wellbeing Board. And again, as the pandemic moves on and everything else moves on with it, you know, we were very much looking back. But one of the absolutely pivotal things within the report were the recommendations that we don't lose the learning. And we had an absolutely excellent discussion of this at Health and Wellbeing Board. And I think depending on whether or not, you know, you take the views of some of the clever folk on the various boards that are advising the government about what happens next if another pandemic comes, and pandemic planning, and the fact that it was apparent that we weren't as well prepared for what COVID did and how it hit and the impact it had. I think both locally, nationally, and obviously there's the mooted inquiry that will happen at some point, but I think just locally, there was some fabulous stuff that happened, and there was some stuff that probably happened a little slower than we'd hoped. One of the concerns we highlighted that I will come back to again is that we were already highlighting how tired the workforce was, and this was way back March time, and we've gone through another wave where hospital numbers have gone up, pressures have gone up. Katie's going to talk shortly on the pressures in GP. So what we consider a huge problem for our workforce, our care workforce, back in March, here we are in November, having had, you know, another 7 months pressure, and judging by what's happening with the winter and things like this, some more to come. So I think, yes, there's some pandemic learning that somehow we absolutely have to capture. And then secondly, we have to make sure that those fire breaks we were recommending for the staff and things like that are also looked at seriously in terms of what do we do, because if we have vital services that either can't find staff, or staff are leaving, or staff are just falling over with stress, tiredness, etc., we don't have much in terms of reserve forces or things like this. So I think so the two things for me about the whole COVID report were, please let's make sure we do have some sort of formal learning process put into place, and that the board ensures that's happening, and ensures that they think as many local lessons can be learned, systems lessons, and also then, as nearly everything seems to eventually, it comes down to ensuring we look after our workforce so that they can still deliver services and care at a high level. Thank you. I think that's the report speaks for itself, but it was a moment in time. I hope that helps.
Thank you. Do you have any questions or comments? I'd just like to thank you for that, Andrew. It's very helpful. I'd just like to kind of highlight one point. I know that this was discussed back on the Health and Wellbeing Board in May, and I just note in terms of the number of survey, and I'm not for one moment dismissing or you know dampening the points that you were raising, but I note that it was 301 people, which is I think about 0.25% of the district's adult population across West Berkshire that was surveyed. And the survey that West Berkshire did was 3,395. And I think it's quite well documented at that meeting, the points that came out, which were in a slightly more positive light, particularly around, for example, engagement with the community hub, communication generally, awareness. And I think the ratings were a little bit more on the positive side, albeit I think we need to be mindful that there are also always lessons learned. And I just wanted to put that into a little bit of context in terms of your report, which of course is always still very helpful to make sure that we're getting that balanced view.
Thank you.
Any other comments or from the committee or anybody else? No? Okay, well, thank you once again to Andrew and Leslie for bringing those points to our attention and for your contribution. So can we move back to agenda item 8? And I'd like to invite Katie Summers to present the report on access to GP surgeries, another very important high profile topic at the moment. Thank you.
Apologies for being slightly late as such. This report has actually already gone along to the Health and Wellbeing Board. So, Chair, would you like me to present this as a formal report, or would you prefer it to be just a discussive item? I'm just very, I don't know how you want to proceed, but you want me to present it, or do you want me to, because it's already been presented at the Health and Wellbeing? Yeah.
I think it would be really helpful for the committee to present the highlights perhaps and draw particular reference to anything that you feel would be helpful for the committee to look at. I appreciate it has been discussed at Health and Wellbeing Board, but obviously our role as Health Scrutiny is to look at specific things outside the Health and Wellbeing Board and often referred from that. But this is a particular item, I think, of interest to residents and very topical.
Okay.
And actually, sorry, just before we come to that, can I just invite Councillor Bridgman to make a comment or ask a question?
It came to Health and Wellbeing Board to some extent because it was a drive from the leader and myself following up conversations that were happening in the community. And indeed, I thought at the time that it was more naturally a piece of discussion for this committee rather than Health and Wellbeing. I thought it was important that Health and Wellbeing considered it in the context of a public meeting, but I do think this is naturally where it might sit in terms of what's going on in the system and the scrutiny of what's going on in the system. That's not the role of Health and Wellbeing, simply to receive information about what was going on in the system as opposed to scrutinising it, which clearly is something for you.
That's fine. Thank you.
Thank you, Councillor Bridgman. Katie.
Yeah, so thank you very much then for inviting me along to this meeting. I would have preferred that actually I was joined here today with one of the local GPs. However, most of the GPs, or all of the GPs, are actively involved in huge amount of pressures at the moment in primary care, so they were unable to join in for this meeting and such. And I think that really sets up the conversation today. So we know that around about 50% of all appointments are face-to-face appointments. And obviously for most GPs, that still remains the preferable way that they will actually organise their workload is through a face-to-face. However, and I think this is where it comes up for the items here for the Scrutiny Committee, the changes as part of the impacts of COVID have meant that most general practices have moved to very much a hybrid model. When I talk about hybrid model, this is in relation to whereby they will use a telephone consultation or where they will do a video consultation with their actual patients. And in most cases, they use that as a way of triaging, first of all, to then identify the most sickest who would actually naturally need to have a face-to-face appointment. And I think that's a really important thing to sort of start off this presentation on. If this is okay, I'm just going to share my system now. I am having problems with IT. I think everybody in the NHS, I will say this, if I cut off, I do apologise, but there is a problem at the moment with IT in the NHS. So if I do cut off, I will hopefully get back into the meeting as soon as possible. So on that front here, what I'm sharing to you has been the impact of COVID-19 in primary care. So this actual diagram here shows you, highlights to you the actual activity in primary care pre-COVID, which is that July 2019 area, all the way up until July 2022. And actually you can see here, there's been a massive increase in the demand in those cases of primary care networks. We had a bit of a dip, you can see in this area here, which is probably in that sort of July area, July 2020, where actually we had the actual lockdown, where we actually did see a drop in activity, but that has escalated substantially since we've moved out of lockdown. So that's really worth you all to know. Now, this is compounded also by the fact that general practice is obviously supporting those people that need to have the expert advice in regarding any health issues, but because also lots of people have had delays in their own elective appointments at trusts or mental health services, they're now having to actually do a backlog of re-referral work into the secondary care services. So that is compounding the pressures in primary care. The next slide I'm going to show you here is looking at the actual percentage of appointments that have actually increased over that period. It might be hard to see on the screen, but what you have here is the age, which is actually on the top of the screen, which is the age bounds, and then you have the actual PCNs. And this shows you the increase of the actual appointments and percentages of consultations have increased from that period of July to July 19 to 2021. And you can see here there is naturally a really big increase in a number of the actual PCNs. It's worth noting that actually some of the PCNs, especially here in Kennet, they're saying actually it's 17%, which is actually quite low. I would actually say this data is a bit out of date. And actually now they've actually checked this, and actually they have actually changed that data as well. So it is actually comparable into the 60% area as it is at the moment. But there is a real big difference here in the number of appointments that they are actually having to see. So the ask here is very much about how we can work collectively together, how the Scrutiny Committee could actually help primary care in actually making sure that they're dealing with only the most appropriate contacts as possible. But I think that's fair to say for all services, whether or not that also be in going into the ED department or in relation to 999 appointments as well. The next slide here looks at the comparisons also of those changes of face-to-face and telephone consultations. So you can see here that some of the areas have seen a decline in the number of face-to-face to telephone consultations, but generally overall across Berkshire West, we've seen an actual increase of 5%. Now, the information here is definitely showing that actually on telephone appointments, they have generally increased. So it's worth you actually knowing that. So what has been the actual impact? So activity, obviously that I've shared here, is only just a snapshot. And this is a key challenge for us at the moment in the clinical commissioning group. Each general practice is their own independent provider. And therefore the way that they capture their information is also slightly different. So one of the key things that the NHS England have recently established is a new programme called the General Practice Data Audit, which sets out some new parameters, which is standardising the recording of appointments, as well as recording also of admin work, which again has been a massive burden for primary care going forward. So I would like to say to the Scrutiny Committee going forward, Once we've got that standardisation through that general practice data audit, I think it'd be fair to say that we could come back with a more realistic, standardised approach, because the data I've just shared with you is just purely percentages. It's very rare, variable, because it's how the individual practices would have actually recorded their data as it is at the moment. So this is a key thing, is the fact that we are working now as a national system in order to make sure that there is better improvement of the data itself. The other thing to note here is we've got information such as the work of online requests. So I put that forward as part of that the general practice data audit. But again, the amount of online requests that GPs are also now receiving is a big challenge for most general practices, because most people now are actually utilising the online version rather than going in and phoning up practices as well. Now, for most people, that is probably preferable. I think actually the working age population probably do like to prefer to have that online functionality. However, it's not necessarily preferable, especially for those people who are elderly. They much prefer to have that telephone conversations and actually avoid availability of speaking with a receptionist in order to discuss their own needs going forward. Face-to-face consultations take longer due to infection control measures. In the past, we had done some audit work in the CCG on looking at the length of time for face-to-face appointments. Most times they were in relation to between 8 to 10 minutes. Because of COVID infection control measures, now most cases are having to be seen within an extended period of between 14 and 16 minutes. So actually there's having to spend a lot more time in order to make sure the following patients that they're seeing in their actual clinic is protected as part of the COVID measures. So this is a key thing. I think also to note here is the fact that housebound patients and those who have difficulty in transport, because most GPs have moved to a hybrid model, we are seeing that actually most housebound people are getting quicker access to a GP. And to give you an example of this, I was speaking with a Wokingham GP this week, and I presented this actual presentation to Wokingham Hosp. He was coming to join me, but unfortunately he got called away. He'd gone to see a housebound person. It was an elderly lady who was 82. And actually he said to me, in the past, because of the workload pressures, we're dealing with sometimes unnecessary contacts. He was able to do those contacts instead of being 14 to 16 minutes. He was able to respond to those contacts with a maximum of 6 minutes. It's freed up the amount of appointments he could deliver in going out to deal with housebound people. So that individual, that 82-year-old lady, in the past, she may not have been seen as a housebound person. The GP might have been able to say, I'm unable to see you. That natural default would have been, you're going to have to call for an ambulance. This lady, because this GP had gone to see her, he was able to manage with her. He was able to speak with Berkshire Healthcare Trust, and they were able to respond to her needs and get a community nurse to help her and have night cover within 2 hours. So that kept that person at home. So there is benefits that we are starting to see as part of that new hybrid model. But I'm saying here that actually this is good for one part, but possibly not good for other areas going forward. What is our individual recovery plans? So at the moment, one key thing that we've done is that we had stepped down the respiratory hub, which was actually part of the Reading Walk-in Centre. And this was actually there to support the actual work of dealing with some of the COVID patients. Now that has now been distributed out to GP practices, and it's fair to say most GP practices are able to cope and manage those suspected of COVID. And the way that they do this is that now, as a CCG, we have commissioned and set out and given out pulse oximeters to all GP practices. So anybody who is suspected of COVID, a GP practice can give out a pulse oximeter, which is fixed on somebody's finger, and then GP practice phones the individual patient on a daily basis and finds out how they're managing. And if they have any early RAG warnings, which is a way that we monitor anybody of their control of their heart rate, their pulse oximeter, the GP can rapidly respond to those issues. And actually, if it needs to be, they can rapidly place them in the raw barks as such going forward. So we are seeing and controlling a lot more of the services going forward in general practice. But further work is still needed to new models of hybrid in primary care. And I think this is a key thing to note. There has been a national there's a local campaign that has literally gone out 3 weeks ago, which is a poster, which is actually informing the local residents about when is it the right time to speak with a GP, when is the right time to call 111. And we really want everybody to actually respond to this going forward. Another example of that, a GP who I said couldn't come to the Wokingham Hospital, he explained to me that actually one issue with one patient was it was a young person who had actually called up the ambulance services 3 times because this young person who had no pre-existing conditions was worried that they had a urinary tract infection. Now, at the time, because of the issues, the actual ambulance service had to go out and respond to this person 3 times, and that was done in the same day. The GP, the actual ambulance services contacted the GP, which happened to that GP, and he had to phone up the individual person and said, "Why are you calling these individuals? We've given you actually your antibiotics. You're absolutely fine. We understand your actual anxieties, but you've just got to let the actual issues that you're having about urinary tract infection actually run, and you will feel better after 24 hours. But this young person, their anxiety levels were very, very high, and the natural default was to call 999. So that's preventing somebody, therefore, of actually having access to an ambulance service that might be of need going forward. But also another key thing is we're in the carrying on with the vaccination programme. So you're all very much aware of the vaccination programme as it is at the moment. And actually most of the GPs in West Berkshire are all part of that vaccination programme, and they're trying to manage that on top of the increasing workload that's been given out that they need to deal with as part of their core general practice. So they've got another key thing here. I'm just going to go build on what we've just said. So improvement around, so I'm just come forward. So the continued work of demand for primary care. So there was a workshop in May which set out some of the remedial actions that were going to be put into place and are currently put into place to support the pressures that are happening in primary care. These are listed in this area here. The key things to note here is the fact that as a CCG, we've commissioned an additional 170 appointments per day per locality to increase face-to-face appointments up till March. The new news for you, which happened literally only on Monday, so you've got this fresh off the press, is that the government have recently launched a new winter access fund specifically for general practice. Each general practice has literally got 2 weeks in order to prepare how they're going to improve access in general practice in order to access that fund. In Bob, we've received £74 million to support that funding. So within 2 weeks, we'll have an individual plan by individual practices in Berkshire West about how they're going to be managing over the winter period over and above that 170 appointments per day. And that is about making sure we have appropriate use of 111, we have appropriate use of the general practice, but also we're supporting additional face-to-face appointments. That said, the key thing here, and I think this was also raised at the Health and Wellbeing Board, is it's great that we're increasing the funding for general practice, but where are we going to get the individual workforce? Now, general practice, we have seen a drop in the number of salaried GPs from March 2016 to March 2021. The drop was 6.8%. There is a huge amount of work going on, and obviously, I think Andy knows about this, about working towards trying to ensure we get as many of the actual trainees wanting to make a career decision to come into general practice. And a number of our GP practices are GP trainers as well. So it's the way that they can promote the activities of general practice. But to build on that, that's not a quick win as such, because you can imagine the training work for recruiting into general practice work is a long-term plan. So the other system that's been put into place is this bottom line here is taking part in additional role reimbursement scheme. Sounds quite, doesn't necessarily describe what the role here is, but I did know that Andy Sharp just talked about this. This is about looking at new additional roles that can be going into primary care networks to support the pressures that are actually in primary care. So new additional roles that all of the primary care networks now have into place are, for example, paramedics, so who can deal with urgent on the day issues. So now you might be an actual resident in a practice in West Berkshire, but rather than being spoken to by a GP, you might have a paramedic that you speak with. Equally, they've employed quite a few now of pharmacists. So a number of people, especially those people with who are frail and have multiple long-term conditions, they might have a huge amount of medication. So you now may be seen by an actual pharmacist in the practice who will do a medication review with you. But equally, they can also repeat any prescriptions as well. The other roles, as Andy Sharp was saying, is there is a major focus of mental health. So actually they're now starting to employ much more of that community mental health specialists in practice, which will there to support the actual low level mental health anxieties, stress or depression, and keep that and remain that in low level. And the final work programs that they've done is increase the number of nurses, and these are advanced nurse practitioners who are qualified to do diagnosis as well as do prescriptions, and also the role of community navigators. Now, the navigators are a really valued role because navigators can help local residents with their own information about how they can actually deal with their own health issues, but also how they can navigate a very, very complex health and social care system. And we're already seeing the real benefits of those actual care navigators, which in some of them have been called health coaches, where they can build relationships with local residents. They can actually help them with their own issues and get the person to be much more in self-control of their own issues going forward. So at this point, I'll end the actual presentation, and I'm happy to actually take any questions. Thank you.
Thank you, Katie, for that very comprehensive overview. Can I, before I open it up to the committee, can I just take Chairman's privilege and just ask a quick question? So I was very pleased to hear your overview of how we are making better use of, for example, pharmacists and other health professionals, which I know was a point that was made by the Health and Wellbeing Board. Can I just ask you, I'm conscious that we have, is it approximately 13 GP surgeries across West Berkshire. Am I right in saying that roughly off the top of my head? Does that apply to all of them, or is this in just specific ones where we have capacity, or in certain areas where we have capacity, or is this happening consistently across the board?
Inconsistently. The way that it's set out is that we've got primary care networks, and in West Berkshire there are, is it 4 or 5? I can't remember. Four. Four. Thank you. I will get all confused. 4 primary care networks. The way it happens is the network, which has one clinical director, but then they bring together the partners who form that part of that network. They make decisions about what staffing that they physically need. In some cases, a community pharmacist might be shared out with several different pharmacies within the actual network. So they may have a community pharmacy on a Monday, and another practice may have that person on a Wednesday or such, but they have a set way of actually organising the workload to share the additional staff out. Some networks have made decisions to actually, based on their population needs, to say, actually, we can't share 1, we need 3, because it's really pertinent for each practice to have that based on their own workforce challenges.
Thank you. Councillor Macro.
Thank you. I'm concerned about the emphasis on, what shall I say, non-face-to-face consultations for a variety of reasons. I do remember reading, I think it was Dr. Mark Porter saying that he can often tell what's wrong with somebody as they walk into the surgery, just by their demeanour, the way they walk, or even their complexion. Also, you lose body language, particularly with a telephone conversation. And I think quite often it's important for the doctor or the nurse or whoever to actually watch the patient's face to make sure they do understand what they're being told. And even with face-to-face consultations, I remember reading that many patients only kind of take in about half of what they're told, because while they're being informed of something, they're also worrying, and they've got several kind of thought processes all going on at the same time. So that's one concern. Also, of course, you've got the issue of people with hearing difficulties, and also people who don't necessarily have the technology, and out in some places don't have very good broadband, for example, if you're trying to do a kind of visual type consultation. But the other thing is that quite often the doctor is not saving time, because the result of the telephone conversation, for example, is a later face-to-face consultation. In fact, this happened to my wife just before I came out today. She had waited 2 weeks for a phone conversation, and now she's going to have to wait till November the 22nd to actually go into the surgery. This is actually the second time it's happened within 2 or 3 months. I'm not sure how much time these phone consultations, etc., actually save. So I've got a great deal of concerns about them. Thank you.
Do you have any comments, Katie?
Yeah, that's fine. I think I agree with you on the body language piece. You only get one part of the story, especially when you're doing things on telephone and such. But I think it's fair to say that actually some people are using 111 and 999. They do get that initial emphasis, and lots of GPs have now had specialist training on actually dealing on a telephone and face-to-face. So they know to hear out for special clues as such going forward. In most cases, a lot of the actual calls, I appreciate your wife's scenario, lots of the calls are just quick answer things, and they could be quickly resolved as such. I think what the issue that we are trying to deal with is that you've had in the past where you've dealt with on-the-day needs, which are urgent as such, and in most cases, those on-the-day's needs could be actually organised in a telephone conversation. You've then got the work of the programme planned activities, which tends to be the work of somebody who's already has a life limiting condition or a long-term condition. And I think this is where we've got to work with the GP practices, which the primary care team are, ensuring that we make sure that the most appropriate people don't have to have that triaging effect of a telephone appointment to wait them for an actual face-to-face. Those individuals need to be earmarked on the GP system to say these individuals are high risk. Don't necessarily do individual telephones. These people could come straight in to general practice as such. So it's a work in progress. I say the hybrid model has only literally been about for a year as such. So it's fair to say that they're all on a big learning curve. They don't want to compromise any form of quality of care. They don't want to compromise safety at all at the moment. And they're all rapidly learning as we move forward. On the point of view of the hearing and hearing difficulties, most general practices have a loop system as such, and all general practices have a way on their system of flagging, and it comes up on the phone call if somebody has an identified hearing difficulty. So it comes up straight away to say this is somebody with hearing difficulties.
Thank you. Councillor Linden.
Thanks, Chairman. Yeah, for a variety of reasons, I see a doctor a few times rather than just once in a blue moon. I've got a slight concern on a few things that maybe needs to look into, and I think on the report that training receptionists are key, because obviously they're not medical professionals. And sometimes if one, for instance, rings up 111 and you get an advice, then you go to a receptionist who thinks, well, I'm going to go through the usual method. It could be a problem. I'm a bit concerned that on that part of the triage, but also IT as well, you know, comparing to the old NHS fax machines. I mean, some email addresses are quite long-winded. The other thing is that when you send an email to a practice and a doctor rings up, you know, I've got a case where the doctor hasn't seen it, but it went to somebody else. And then you're going back to the same triage that you have a phone call to have a phone call rather than getting an appointment. And also the phone call returns. I was quite lucky when I got a return back from my doctor. I had to say that I had a licensing subcommittee in the way, and he did ring back before that happened, because if it's the whole morning, you know, and you've got other things doing, you know, you don't know when they're going to ring back, and possibly some timelines. I'm going to ring back in a half an hour slot or an hour slot, makes it easier for people to organise their day, especially if they're working or whatever. So it can be a bit of a difficulty. I mean, it may speed things up, but you've also got to look at, you know, what people are doing. I mean, for instance, my mother, you know, she doesn't use IT at all. So that would be completely utterly useless other than the main phone. So, and she doesn't have a mobile. So I think it is important that we need a degree of flexibility, but also knowing how the IT works, and then getting a response back. It's still going to work. You know, it's still work in progress, I think.
Yeah, thank you, Councillor Linden. Yeah, it is work in progress. I'll start with that first one about digital literacy. There is a programme of work that has really kicked off in a number of the GP practices to support the phrase that's used is digital inclusion. It's very much targeted at those people over the age of 65 as such. And that's working directly with Age UK. Age UK is now allowing for some individuals who don't necessarily have equipment. Equally, they don't necessarily understand about how to use the equipment. Age UK are going out to those individuals and providing iPads and also providing some of the individual training as well. So there is a programme of work that's already in place to support that going forward. On the point of emailing practices, what each practice has in place at the moment is you wouldn't necessarily email your practice, you would go onto their website. On their website, which is through a system called Footfall, you put in, I need to talk to a general practice. And all you just do is type in your query as such, and then that's logged in the GP system. There's already admin staff in each GP practice who is constantly reviewing those actual messages. In most cases, they say that actually they get back to the person within 24 hours, but in my awareness, most people respond to those within 2 hours as such. They then actually get the GP, they suggest a time when the GP is going to telephone them. At that point, if there is any issues regarding telephone, then the individual receptionist does actually say, would this be beneficial to actually rather having it, if you're going to have problems, would you be able to come in as such? So I'm not 100% sure where you're emailing as such going forward, but maybe we can talk offline and I can speak with you about this going forward as such.
Yeah, if you want to send me to my councillor's email account, and then I can just describe what would exactly happen on that occasion. But it's for members of the public. I mean, it's not just, to be honest with you, the people over the age of 65. I'm approaching in a couple of years' time, but it's going to be people who are not into IT at all. Some people who, you know, they may not have severe learning difficulties, but they may not be, you know, educated or whatever to go on to IT at all. I mean, you've got to look at that sort of occasion. I mean, actually, what I was going to say is I took a photograph of what I had a concern about, and it went to another doctor, and then it went through the whole process again. So I was trying to reduce the time and saying, is this a problem or not? The doctor then said it isn't, but I'm seeing from a few other things on Thursday. But I just think we need to go a bit more seamlessly, but we've also got to consider people under the age of 65 who may not have the wherewithal to do it, you know, or they may be busy, or they're stressed, or they've got a young family or whatever. So I think there's various reasons that not everything works as well as, you know, you can do.
Okay, thank you. Gordon, would you mind putting me in contact with Councillor Linden? Would that be okay? Thank you.
Thank you. Before I come to Councillor Moore, can I just make my own comments on a couple of points that was raised? I actually concur with Councillor Linden in terms of the piece around calling you back. My GP surgery was very good at calling me back. However, I had no idea when they were going to do that morning. And actually, I missed the call because it didn't ring properly on my mobile. And it was actually quite a stressful experience, because once you lose that slot, you're almost back into the system to then recontact. And if you can't get through, you're almost waiting till the next sort of day sometimes to get back through. So I think that is one point that just to highlight from my experience. But actually, Katie, I wanted to ask you more widely. You've shared a lot of really good information generally for the general public, for our residents to know. Do you think we're doing enough to communicate that in terms of, you know, various things that you've mentioned that are very relevant? Are we doing enough to get that out? And I noticed on the Health and Wellbeing Board, one of the points that was raised was perhaps a lack of communication with patients. Are we doing enough? What more can we do? And is there a role for us on this scrutiny committee, or indeed more widely within the council, to help?
So I think this has been talked about with Councillor Bridgman at the Health and Wellbeing Board. And if this is right with you, Councillor Bridgman, I'll bring you in here. But what was agreed at the Health and Wellbeing Board is there is a role, I think, for most of the members to actually help and support the communication of what is appropriate to such, and giving out the messages of the pressures and demands that are currently happening in general practice. General practice, they're on their knees at the moment. But I would say that, I say that, but in hindsight, I'm saying this to anybody in the NHS, they're all on their knees as such. But I think you don't necessarily hear it in general practice. You hear a lot about it in the press about what's happening in the emergency departments. But the work of what's appropriate to come for referrals for general practice would be really good. There is this leaflet that's actually been a poster that's been promoted. I would actually see if this is okay with actually all the members, if they could get hold of the actual leaflet and actually use this in your promotion work that you're doing with your own constituents. I think that would be very, very helpful. I think also, if you are having any specific issues, I hear what you yourself, Councillor Rowles, have actually said about the waiting times. I'll take that back. I will ask the primary care team to actually get an audit done of the actual waiting times and actually get the individual practices to then set out what that waiting time is going to be in order to respond as such. I'll take that away and get that sorted for you.
Actually, thank you. Yeah,
yeah.
My point was more around managing your expectation, actually.
Yeah.
I think they were very good at coming back. They were very responsive. It was more a communication point around, even a rough idea of that slot instead of the whole morning. But, I also want to make the absolutely clear that I think as a committee, we recognise the pressures, we recognise the challenges. It is all everybody's interest to work together. And I think if we can certainly help pump out the messages through social media, through our own surgeries, through our own connections with our residents, that's something that as a committee we should be championing. And I would certainly like to help drive that forward. Councillor Moore.
Thank you, Chair. Thank you again, Katie. I just want to follow a couple of threads that have come through in those last conversations. In particular, the hybrid model, and you said, that surgeries practices are, it's all pretty new. To what degree are those practices individually developing their own way of doing things? I suspect that a lot of what we get in terms of expectations of the health service is anecdotal. My mum knew this, or my brother did that, and of course they're potentially all over the country, if not all around the district. And is there any kind of evidence of a sort of an attempt to get some kind of consistency on the hybrid model, and then, if you like, manage expectations amongst the public of, what sort of bit of the hybrid they're likely to receive if they've got this sort of situation?
Yeah, thank you, Councillor Moore. I think to just reflect on this, there are 13 GP practices, they're independent businesses. However, now we've got 4 established primary care networks. Each network has an individual memorandum of understanding about the business models that within the practices within that network that they will be sharing as such. So we have that now within the individual primary care networks. And also I want to celebrate the fact that the networks are also starting to share their own business models, their own approaches across Berkshire West as well. And I think this is going to be really helping the way we work in a standardised model as such for the local residents of West Berkshire. So there is a commonality of the process going forward. But I want to reflect in saying a model that would be somewhere like Kennet PCN, which is obviously quite a, would I say, urban sort of area, would be very different to West Rural as such. So you need to have that flexibility on what that population individual needs are as such. So I think the confidence for yourself, Councillor Moore, is the fact that the networks all have this individual signed memorandum of understanding, a signed contract that they all physically have signed up to within those individual practices, that they will share their own business models going forward.
Okay, thank you.
Thank you. I just have a couple more questions. First of all, I'm very mindful we've just spoken about mental health and well-being in our younger community. What are we doing anything to help support our healthcare professionals with mental health themselves? That's my first question. And what kind of things we're helping them with, just to sort of help with the motivation around their role, because at an incredibly challenging time. And actually, secondly, you mentioned about our role as a health scrutiny committee. I'm interested on your views on what we should be doing specifically to support them, or what we should be doing in our role amidst this.
Yeah. Also, on the point of view of their own well-being and their support, there is national work that's going on for this. So the British Medical Association is offering, as well as the local Medical Council Association, are offering lots of wellbeing advice lines and support for individual clinicians who have actually gone through quite a substantial burden of work as such. I think it's fair to say that actually, if you think about it, in our war environment, most of the actual Army or the Royal Air Force or the Navy, they are deployed for X period of time as such, and then they come home decompensating. We, as part of lockdown, have not had that area of letting down. They're living it on a work life, as well as coming home for it at all. So most clinicians, it's just not GPs, but it's nurses, OTs, social workers, everybody has really felt this. But from a purist GP perspective, the LMC and the British Medical Association have set up advice lines, they've set up support, they've set up additional counselling for GPs, and the same thing has happened through the Royal College of Nursing as well. So they have that capability as is at the moment. Your second point on what should you be doing, I think generally you probably hear from your constituents, I can't get access to my GP, I've got problems such going forward. And actually, I think you've got to give out that poster message to say, this is the pressures that your general practice is currently under. They're here to help and support you. If you don't feel that's the right thing to go forward with, what I can do for you as the Health Overview Scrutiny Committee, which I've just recently done in Wokingham, is give you a list of all the practice managers where you can physically then send that individual complaints through to, so get that individual practice manager to actually physically respond. I don't know if that's going to be helpful.
I think that would be very helpful, actually. I think the committee would agree that that would be a very helpful action coming out of this meeting. Thank you very much. Are there any other questions, members? Okay, well, I think that was incredibly helpful. And Katie, I'd like to thank you for your input on that and your thorough reporting back to us. There is no recommendation with this report. Members are simply asked to note the report. So moving on to agenda item 9, CCG update. Again, Katie,
Yep.
over to you again.
Can I just ask, Chairman, I'm late for another meeting, so I could stay for another between 5 and 10 minutes, and then I've got to go. It's very pertinent because I'm planning for a conversation that's needed for you as vaccinations and such. So if it's okay, I could probably stay for another 5-10 minutes.
Yeah, no, that's absolutely fine. Well, perhaps, I mean, hopefully everybody's actually had time to read the report. Shall we just go straight to questions? Because I think that would probably be the best use of time. Members,
there is a report, is there?
Oh, sorry, it's a verbal report, isn't it? Sorry.
Yeah. So I'm just going to show.
We have so many reports in this pack. Apologies.
I'm just going to share my.
Just give us a verbal report, thank you.
Yeah, I'm just going to share my screen again to just give you a bit of an overview about what's actually happening. sorry, this is my meeting. Hang on a minute. They're trying to get hold of me.
Perhaps if you can just draw on the highlights in view of the time.
I'm just going to show you a slide if I can get it on the screen. Okay, let me try and close this bit down here so you can see it a bit better. So this is sort of a bit of an update about what's happening as the CCGs. So the first thing to say is that CCGs will no longer be in existence as of April 2022. What will be forming moving forward is what's known as an integrated care board. And the integrated care board will be an integrated care board that sits for Berkshire, West, Oxfordshire, and also Buckinghamshire, known as Bob. The integrated care board will have all of the actual staffing, which include myself, will become members of that integrated care board, and that will be from April 2022. Then there's several other groups that are being formulated. The first one is called an integrated care partnership. Please don't get this confused with what we have in place. I'm looking at Councillor Bridgman who's laughing, with the Berkshire West Integrated Care Partnership. The integrated partnership here will be a Bob Integrated Care Partnership, which will have members from all of the relevant organisations, and I think James Kent has been meeting with the leaders of the councils as well as chief executives over the past couple of months about the establishment of this integrated care partnership. But what is asked here is the fact that there will be one integrated care partnership for Bob going forward. That partnership will be a partnership that basically looks at what all the activities are going through the actual, what's known now as the place-based partnerships. So Berkshire West ICP will be renamed the Berkshire West Place-Based Partnership. That place-based partnership, their main responsibilities here will be to support the population health needs of the individual Berkshire West. We will still have the sovereignty of actually having the individual West Berkshire, Reading and Woking and such, and there will still be the need to actually ensure that there's high level representations from those individual councils going forward. We are going through a system at the moment of looking at what should be the delegated functions. So if you imagine the CCG has core statutory functions that are set to us by the Constitution and by the Secretary of State, all those functions will be transitioned up to the ICB. The Integrated Care Board, ICB, obviously that's serving a population of 1.8 million, but what they're looking at the moment is what are those functions that should be delegated into place-based partnerships. So this is an active conversation that is still going through at the moment, but this is a key thing for you to note. The other thing to say here is we are going forward at the moment, and hopefully I was informed by Dr. James Kent, who is the current CCG Chief Executive, the appointment for the new ICS ICB Chief Executive is supposed to be announced on the week of the 15th of November. So hopefully by next week, and the communication will be coming out about who's going to be that new Chief Executive. We've already got the announcements of the individual chair, which is a gentleman called is it Sadiq Khan? I can't remember his name. Sorry, I have to find that and give that to you, Gordon. So you.
I thought that was the London Mayor. Sorry.
The names are very similar. Names are very similar. I keep on getting.
If I may interrupt, it's Javid Khan.
Thank you, Javid Khan. Thank you. Javid Khan has been. Yeah. The individual non-exec directors, their recruitments are going to be coming out next week as such for appointments as such. They're not being advertised, but they're going to be advertised next week. So there's a huge amount of work that's going on at the moment in the creation and the transition from being a Berkshire West CCG into an integrated care board. I think that's the best thing to sort of say at the current time as such. I don't know whether Andy Sharp, if there's anything else that you wanted to add in at all.
Andy?
No, thank you, Katie. I think you described that much better than I could possibly have done. Thank you for that. It's very clear.
Katie, as we don't have a written report, could we possibly have a copy of that slide, which I think is incredibly helpful for our benefit, actually, so after the meeting? Thank you. Yeah. Councillor Bridgman.
Chairman, I can share that slide with you very straightforwardly if you want me to. After the meeting, I've got it. Simply to say, as Katie will know, the NHS's ability to use the same acronym, in this case, for the third time, and confuse everyone, ICP, is absolutely phenomenal. And just to say to Katie, one thing I will be interested in, Katie, as we go forward, and you know I'm sort of fairly involved in all of this, is the legislation that will need to come forward, because of course the Health and Wellbeing Board has two CCG representatives as a matter of one of them as a matter of statute, and one of them, because we've appointed another one, on the board. So we're going to need to work out what the relationship, and I'm sure that will go for all the health and wellbeing boards within Bob, what the relationship is between Health and Wellbeing Board membership in particular, and the hierarchy of the NHS as we go for the hierarchy of Bob as we go forward. But I just take your indulgence, Chairman, to ask that, not that it affects health scrutiny in particular, but those relationships need to be worked out because they will affect the way in which you work.
Thank you, Councillor Bridgman. Actually, just for my own benefit, my understanding is that there will be representatives of this committee feeding into Bob. Is that right? Am I right in saying that?
I think you'll be feeding into scrutiny.
Right.
From the point of view of Joint Health Overview and Scrutiny Commission, but not necessarily in the sense of representation. There will be at the moment, the intention is to have one local authority representative on the ICB board, and there's a whole discussion about how that's going to come about. And then what I'm particularly interested in is our representation on the ICP, because that's really where those conversations will take place. That structural place conversation will take place.
Thank you. I think that's just helpful to clarify in our own minds. Thank you. Councillor Bridgman, your hand is still up. Oh, no, it's gone. Thank you, Katie. Is there any other questions from members?
The only thing I just want to add on what Councillor Bridgman was saying is I've reviewed all of the guidance, and I'm sure that you all have at the moment, about the structures and what's taken forward and so forth. What's quite critical is understanding what's going to be delegated through to the place as such. That's the most critical thing. Now, I think this is where it comes into the role of that place-based partnership for Berkshire West is the critical thing going forward, to make sure we have the right structure, we have the right form, and also the right governance routes going forward. So it's actually ensuring that how is the scrutiny committee going to have that reporting up and down through that place-based partnership as such, which would be the critical thing, I think.
Thank you. Councillor Moore.
Thank you. I just wonder whether there's obviously a fairly significant, it feels to me, change, and not just of initials going on here. Is there an assessment going on in parallel with that change to make sure that in effect nothing drops through the cracks?
Yeah, there is a complete, thanks to NHS England, we've got an actual review of all of the individual functions, all of the different statutory roles, all of the different work programmes. It's all being captured at the moment. It's all being reviewed as part of that transition arrangement as such. I mean, feel very, very reassured that actually is there, but you as a scrutiny committee might want to actually say, could we have an update about what's actually happening as part of that transition? That would be fair to say.
Yeah, and thank you. Just following on from that, I think we are going to ask for a briefing. So I know that Gordon's looking at that. Any more questions, members? Well, thank you very much, Katie. Yes, of course. Do drop off the call. Thank you so much for joining.
Bye.
Thank you. Bye-bye. Okay, just moving on to final agenda item. Oh, sorry, Councillor Bridgman. Did you have something you wanted to say? Oh, it was
a legacy hand, but I will say that I'm about to share that that slide with you, all of you.
Thank you. Thank you very much. That's very helpful. So moving on to final agenda item 11, work programme. So I hope members have had a chance to have a look at the work programme and the informal briefings. I do invite members to put forward further suggestions for additional items, either at this meeting or the next, or in between meetings. As we've mentioned before, all proposals will go through the prioritisation tool and will be considered by myself and the Vice Chairman ahead of the next meeting. I'd also like to just highlight, before I take any comments, that there is a form on the website to allow people to nominate topics through for this committee to consider. So for the members of the general public, that is available. Are there any comments or any suggestions? No, okay, well, I think it's going to be ongoing, looking at things, particularly topical things that come out that are referred to from health and wellbeing and from other committees potentially. So we will, that's pretty much work in progress, I think, as we go. Okay, members, so I think that's all the business that's concluded for now. I'd like to thank everybody for their attendance. I'd like to thank all of our external attendees as well. Thank you so much for your input. We very much welcome your input and your valuable time. Please, can all panelists remain in the virtual meeting room until the Zoom host has confirmed that the meeting is no longer live streamed. Thank you very much.